Thank you, Aspetar, and everyone who's out there in the online forum. So, the title Focal Extracorporeal Shockwave Therapy, what works, what doesn't work, and what may work. I've taken a liberty for my final lecture to actually change the title a little bit. So, instead of what doesn't work, it's more of what is more difficult to treat. As all of you would know, and I would probably tell you, shockwave can work in many ways, and it can work for many injuries, and it almost works on every injury. It's just how much you are able to use the placebo effect or the treatment effect to reduce the pain and to promote tissue regeneration. And in late 2014, I took this picture with the grandfather of shockwave in Vienna. His name is Professor Wolfgang Schadden. And we spent a week together in his clinic and in his hospital in Alva Hospital in Vienna. And I took upon myself to actually learn as much as possible as a very excited young physician at that point. I have no conflict of interest, and over here, this is the picture of my department. I would like to thank everyone in my department for bearing with me, and I has been very, very shocking all this while, and very, very motivated doing it. I thank all the surgeons, the NSMP, rehab, and research department, and everyone who is seated here, all my patients, Ken over there, for starting the plantar fasciopathy pathway, and that was a good starting point for us. The objectives of this talk is to identify the most common injuries. After that, we will go to look at the list of conditions where shockwave therapy may not be indicated or may be difficult to treat, and to describe conditions where focal shockwave therapy might be useful. And obviously, we need to look at the safety aspects of focal shockwave therapy. And in this picture, you can actually see the device that we are using. This is an electrohydraulic focal shockwave, and this is one of the applicators, which is a focal applicator, which we use for treating bones. And if you look at the link down there, that is the previous lecture that I did a year and a half ago on the innovation of a focal shockwave. What's today's news? We need to know what is focal shockwave and how it does work. Why did we study it? Who helped us through? And what is the methodology that we use if you actually want to do a chart review or a registry? And we need to look at the findings or the results. What works, what is difficult to treat, and what are the potential treatment that we can use it for. And finally, what is the future? Over here, you can see that we have a picture here. I would like to show you how the focal shockwave is produced. If we can get it to work. Okay. All right. As you can see over here, this is the applicator head. The water fills up in the head, and then in the middle there is a spark plug, and that spark plug produces a spark which is transmitted through the device and through the gel into the tissue. Okay, if you want to see it again, we can always play it again. See that they use a liquid which is water-based, and inside there's a spark which is produced, a waveform is produced which is passed through, and this is the shockwave electrohydraulic. We need to understand what is the mechanism of shockwave, how it does work. Okay, and over here we understand that there are three phases, of which firstly is the physical phase where the shockwave is generated, and a positive pressure goes in and is either absorbed, reflected, scattered, or transmitted. And this would depend on what are the angles that you actually apply the probe, and what it is a tissue that you are applying it to. And if it is a tissue which absorbs the energy like bone. It might actually break bone, or it may stimulate healing. The chemical phase involves the is the result of the mechanical stimulation, which leads to biochemical reactions, where biomolecules are released and cell signaling pathways are activated. So it is not just mechanical, it's also chemical. And subsequently, you have the biological phase, where modulation of angiogenesis and alteration of inflammatory response and bone and soft tissue healing occurs right here, as you see. So these three phases are important to actually help to provide the effect of shockwave. So it is not just placebo. It's not just a very good placebo. Just as you can see, there's a sound, tuck, 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 tuck. There is light. There is a doctor wearing his lab coat. And there is also, if you're seated right at the top of the food chain, where the surgeon says, go and see this guy and he will help you. No, there is actually a mechanism for this. Okay, so if you look here, this is the waveform which is produced. And there's a parabola which helps to focus the shockwave. And in each applicator, the area of shockwave where its focus is differs depending on whether you want a very strong effect or whether you want an effect going in for tissue healing where it is less focused. And if you look at this small graph over here, this is a pressure graph where you can see that once the spark plug produces a spark, over here there is a sudden change in pressure in the device and a waveform is actually produced and propagated. And now we want to find out, why are we studying this? First of all, there's not enough evidence looking at the efficacy of focused shockwave in athletes, as most of the studies are done in non-athletes. Secondly, the previous study outcomes were inconclusive because you are using all different devices. Even in focal shockwave, you have electromagnetic, piezoelectric, and the gold standard focal electrohydraulic shockwave. And then you have the radial shockwave, which many people use. So everyone uses different devices and different protocols with different dosing and different energy levels. There is also not enough evidence looking at the safety of focal shockwave. As we all know, most of the work has been done with plantar fasciitis and Achilles tendinitis. But if you look at some of this data, they did not actually do a lot of imaging. And over the next few slides, I will explain why imaging is important to actually differentiate some of these things, as they are not the same. And obviously, if you look at the limited studies of the outcomes amongst athletes and sedentary patients in electrohydraulic shockwave therapy, despite being the gold standard. And this is the story of how we started and how we are at this part with our shockwave project. And as you know, Dr. Hakim Chalabi asked me what we need to do in Aspetar in 2012, after I finished a year of my stint in Aspire Academy. And I said, maybe we should do a focal shockwave because there's lots of patients who are actually waiting to be treated in the rehab department who can be helped with just shockwave because they don't need a rehab for a prolonged duration. And we also have lots of athletes who will benefit from it. And I remember in the year 2000, I was preparing for an athlete to go for the youth field hockey world championships. And we had to go to the equestrian clinic to get them to provide us service with the focal shockwave device. So that was my first encounter with that, and it worked. And the chap played, and he did very well. And subsequently, over the between 2005 and 2011, I did use the radial shockwave, and I found that it was not so great. And it was a great opportunity to actually have this device, which is a focal electrohydraulic shockwave. And Professor Rolba was very helpful because he said, you need to document what works and what doesn't work. And he says the best way is to actually do a registry. And since then, from the first patient in January 2015, we started documenting every single patient, what happened to them, what are the parameters of their treatment. And we have Rod Whiteley. He's everywhere in research in this hospital. And he was very helpful. He said, whatever you do, you need to make sure that your data, what your outcome is simple and reproducible. Okay, what is simple and reproducible? The pain scores, the patient perceived outcome score, which is 5-point Likert scale. And we started collecting that. And we have Karim Shumari, who was very helpful to encourage me on tweaking some of the methodology. And without Aziz, none of the statistics can be studied properly. So he helped me every year with the audit. And we presented almost every year in the international conferences. And we have my boss, Dr. Luis, and Marco Cardinale, who actually provided the leadership and the research guidance. We had Professor Matt Brisberg, who was there during the initial phases, and he says, for cartilage, focal cartilage lesion, the subchondral bone edema is a very important part because it provides the nutrition to the cartilage. And I said, okay, let's have a look at it. And we started treating cartilage lesions with bone marrow edema. And the other side, on the right, we can see the faces of the Austrians and Germans because they are the pioneers in this field. And mind you, there was also a pioneer who was from Yugoslavia, but somehow did not get the prominence in the industry. However, saying that, the grandfather is here, Professor Wolfgang Schaden. The other two young chaps provided me the motivation. Is this young people can also do shockwave, not just old people. And Professor Carlston, who is a hand surgeon, Sergei Thiele is also a surgeon, but now he's doing some manual therapy, and he's a mix of everything. And Vincent Osberg is also an orthopedic surgeon, and it was strange to me why surgeons would want to do shockwave. They should just operate. But I figured this must be something really important for me to get into. And we have this guru of fracture treatment in Hanover. So Dr. Frank Butcher was one person who inspired me. He did the highest number of fracture treatment in the world, I believe. And that's where I actually spent 10 days learning from him. So without everybody's support, everybody's referral, and even all the patients who actually offered their limbs to me to be shocked, even though it was painful, I thank you all. So we look at the methodology. We started as a chart review or a registry. From 1st January 2015, I just mentioned to Dr. Lewis that we have data until 12 August 2024. If you're interested to have a look at it, it's in the research server, and all you have to do is to speak to Dr. Lewis about it. And we took all consecutive patients treated with shockwave and had their indication, treatment outcomes, treatment parameters, and adverse events recorded. We included all patients who were 18 and above, providing informed consent, and those who were able to tolerate the treatment. We excluded those who had recent treatment with PRP, corticosteroid injection, those who were taking NSAIDs, multiple limb pathology, those who had the double anticoagulation. Why do we not allow people to take NSAIDs or any form of local anesthetics? It's because if you knock out the pain, I don't know where to shock. And if you don't show me where to shock, then I may shock in the wrong place and the patient may have no response. So it is a pain target treatment process, just like the wide awake local anesthetic surgery that some of the surgeons do. We need the patient to be well aware of where the pain is coming from. So in 2016, we did our first audit and we realized that most of the patients needed less than 2 treatments. That's where we actually continue with the treatment with 1 to 3 treatments only once in 2 to 4 weeks. More so for the fact that we don't have available treatment slots, and we found that it does take time for tissue to heal. They don't just heal instantaneously. You can actually remove the pain, but for tissue healing, it takes time. So 2 to 4 weeks is good. When you look at energy flux density, you would obviously start with a lower energy, not always with 0.08, but this is the range that you would have, and you go to the highest energy level, which is 0.27 in this device. The usual frequency which is used is between 4 to 5, but sometimes you will use a lower energy if you need to have a maximum effect, because when you go with a higher energy, what happens is you hear the sound instead of pop, 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 where you actually know the real shocks are going in, not just the sound. Okay, so you need to know how the device works. If you don't know, you'll be shooting nothing inside. So when you go faster, sometimes bubbles develop inside and you cannot get an effective shock. So follow-up is done every 2 to 4 weeks until discharge. And once the patient returns to play or is happy with the treatment, we discharge them. Data is collected every time that we see the patient, and obviously we include the age, gender, BMI, indication, duration of injury, the region, the tissue type, the site, number of treatments, the pain score before and after treatment, the pain change, pain perceived outcome, which is 5-point Likert scale, the adverse effects, and also the treatment parameters. And if you want to know more about the protocol, please ask me and I can actually provide you a copy. And over here, there is a link that you can go to, which is down here, which shows the ISMST, or the International Shockwave Medicine Society, approved guidelines for indications. Now, in Aspetar, we talk about the targeted approach. Why targeted approach? Because everyone uses a different device. And sometimes we use a different applicator because not everyone buys 3 applicators because they cost a lot of money. So with each device, you can achieve a certain amount of outcome. Okay, so I guess someone is calling me. Right, madam, yes. And with the different applicator, you will use it for different tissue, different indication, whether you want pain relief or you want tissue healing. So be aware, if you don't know what you are treating, you are in trouble because you're just putting the probe there. And there's a possibility you may have more pain. There's a possibility your patient will not benefit from it because we charge a lot of money. The next thing is tissue type, whether it's a tendon, ligament, fascia, or bone. Tissue type like bone would require the highest possible energy level, where if you're trying to break osteophytes, it will go all the way. When you're trying to promote healing of bone, to promote osteoblast activity and to reduce osteoclast activity, you go all the way to the maximum. However, you are treating a human being. It is not a horse. Although they started using shockwave for animals, but your patient is going to tell you, stop, I cannot tolerate anymore. So sometimes we have to go according to what the patient can tolerate. And you need to look at the nature of injury, the indication. If you are going for tissue healing, for degenerative tendons, or if you are trying to treat fascia with a partial tear, you will need to go with a lowest possible energy within the therapeutic threshold. However, if you are going for fracture healing, where you shock in between the gap of the fracture, you will need to go for the highest tolerable energy level with this device. Okay, unlike the biggest device which you use for kidney stones, this moderate device is actually very safe. So you don't have side effects like huge hematoma and other potential side effects, which is related to a very high energy level, like a tendon rupture. So you will never have it with this energy level. Mind you, some people say, you say never. Never say never, because one can have a spontaneous tendon rupture even without doing any treatment. So it can still happen. The size of the lesion will depend how many pulses you actually provide. If you are treating a small sesamoid, you would give probably 800. If you are treating a little toe, 800 pulses is more than enough. If you are treating a long bone fracture in the femur or a tibia, you will probably go to 1,400 up to 2,000. But over here, we had difficulty because we had too many patients and not enough slots. So we had to split the 2,000 shocks into 2 treatments. But if you have a little bit more time, you'll be able to treat that patient in that one session. The beauty of it is, with a smaller device, you don't need to use the local anesthetic. The location of the affected tissue, obviously, if it's very deep, you will need to use a higher energy level. You will need to use the probe, which is more focused, to actually go deeper into the tissue. And you can actually adjust the depth of the focal energy going in with changing the curvature of the membrane of the applicator head. Now, the next 3 items. So you look at a combination therapy with rehab and other treatment as the way to go. We do not use monotherapy. Unlike a lot of centers, when I first started going into focal shockwave, they were saying monotherapy is all you need. You just do shockwave. And then as the studies came out, you know that plantar fasciitis, Achilles tendinopathy responds better with focal shockwave with rehabilitation. So the next thing, we need to have accessibility of care. Okay, if your patients do not have their consecutive treatment within your 2 weeks to 4 weeks, sometimes they get lost, they get disheartened, and you do not have the full possible outcome. And obviously the comorbidities, if you're treating someone with plantar fasciitis, with coexisting knee osteoarthritis, with a low back pain, that would be disaster. So I get a lot of Dr. Yassin's patients who are a complete nightmare. So I tell them, you need to fix your back and fix your knee, and then we can talk about fixing your foot, because if you have 3 possible problems. So the next thing is, how much pain can your patient tolerate? And you know that some patients have hyperalgesia, especially when you look at patients who have been suffering it for months. There's a lot of hyperalgesia. So not everyone can tolerate the pain score of up to 7 or 8 out of 10. So in that case, we need to stagger the treatment. Or we will tell them, please go and see Dr. Yassin again. So the next thing is, it's important to have the skills. If you are just starting, it will take some time before you become an expert practitioner. And I would say young people are very good because they are very enthusiastic, so they tend to move much faster. So the more time you get to do the cases, if you achieve the critical mass, if you do 2 sessions a week, you will learn this very fast. But before you can do the 2 sessions, you must make sure that you are able to do the 1 session. And over here, this the first thing is the parabola that you will use to focus the shockwave in the device. So depending on the different sizes and the different shapes of the parabola, you will focus it differently. And this is a very interesting study where they look at the myocardium of the heart and how it actually responds to shockwave. And they found that the shockwave energy flux density, where it is most useful for healing, is between 0.1 and 0.15. If you go below that, it doesn't really work. If you go above that, you have cytotoxicity. Instead of healing the tissues, you actually kill the tissues. Okay, so if you are actually looking for tissue healing, you will need to go within this range. So all people talk about is what works. Nobody ever talks about when it does not work. When you're in trouble, what do you do? And this is when I will tell you the nightmares I have. So when it does not work, you need to reevaluate your diagnosis. You need to think about a possible combination therapy. And over here, it's an interesting picture that Dr. Frank Badger did. A calcaneal fracture with two shockwave devices, although with the electromagnetic device. So this changes how you actually treat. I thought it's always use one, but he used two. I suppose you can even use three. That will shorten the duration. So you think outside the box, and obviously do your rehab, do your other treatment that your doctor is telling you. And the next thing is image guidance. We have the ultrasound device over here where you can actually identify where the calcification here is and where the tear is in your tendon. So it is also useful. That's where imaging is very useful. So when you don't have imaging, you do it blind. When you do it blind, what are you really doing? We don't know. So always be aware of comorbidities. If there are comorbidities, they may be the confounding factor causing your treatment not to work. And obviously, if your patient is non-consenting and telling you, no, I can't tolerate the pain, I can't take this anymore, I will not come here. So maybe that's part of the thing. And if the patient is non-compliant, we have some athletes who are really not going to stop playing, who are really not going to start jumping and running or sprinting just because you tell them they need to reduce the training load, and they will not get better. And the next thing is, there are times that you need to stop. And we will see over the next couple of slides, when do we stop. And sometimes you need to use a big device for a big fracture. Where you actually reduce the number of treatments to one session with this device. Here is a busy slide looking at different tissue types and then the different indications and the type of applicator that you will use. And with that, the different energy flux density and different criteria that you will use for treating these injuries. So it is a whole jargon that you will have to understand. If you don't go with anything, this is one thing that you go with. This is a recipe book that I've actually come up with. So this is the Aspetar way. If you look at bone, if you look at fracture or ossification, you go for a higher energy flux density. And preferably, if there is a fracture, if there is a defect seen, you would go for ultrasound guidance. And if you look at a joint, if there is a cartilage defect with bone marrow edema, you'll go all the way with a focus applicator. But be aware that if there's joint effusion, it will affect how your focal shockwave is actually going into the tissue. So I tend not to like joint effusions. And then if you look at those with impingement of the patellofemoral joint or fat pad impingement or inflammation of the synovium or even a plica which is inflamed, you can use the unfocused, which is preferred, and occasionally when you don't have the unfocused device, you can use a soft focus. So you can see this is a very low energy level that you will start with, and you will gradually increase to not very high. And if you have a tendon involvement where there's inflammation or whether there's a partial tear or tendinosis, you go with a much lower energy level, and you will combine with rehab. Don't go with monotherapy. And we only treat those with less than 50% of a tear. Okay, why? Because we find that those who have a higher amount of tear don't tend to respond very well. At least in my experience, there may be some people who are better than me. Okay, so if you have calcific tendinitis, you go all the way. If you treat a smaller tendon, it's often difficult to go all the way because it's very painful. So you go as high as possible within the threshold. And ultrasound guidance is preferred. But if you can actually palpate the whole calcification, you don't need ultrasound guidance. So when you look at fascia and muscle, whether it's fasciopathy and myofascial pain, you can go a little bit higher. You don't have to start with 0.08. If you're using the unfocused, you can start with 0.1 up to 0.14. Always combined with rehab or home-based exercises. Mind you, not everybody who's unfit, obese, or sedentary who comes to my clinic will get physiotherapy. All they need to do is to start moving and start doing some of their isometric exercises, start doing some strengthening, and most of them are discharged with just that, or OPD physiotherapy. And for ligaments and skin, we don't do a whole lot, but if there's a partial tear, go low. If there's ossification, you can go a little bit higher. If it's a small ligament, you use a lower energy level. If it's a big ligament, you can go all the way. For skin, we don't treat a lot of non-healing wounds, but you can actually use the unfocused probe where it's suitable for healing, and I use a sterile film barrier. But for painful scars or hypertrophic scars, you can actually use also shockwave. So we find that some of the surgical patients come over to us to get the pain released so that they can actually progress with rehab. And over here we have the demography, where we actually treated 1,413 patients, where most of them were males and non-athletes, and they required 3,050 treatments for 1,778 indications or injuries. And the mean age was slightly higher, 41.5, and a BMI of 29 because of the sedentary population. We find that for athletes, the most common sports is football, followed by volleyball, handball, basketball, and athletics. This may differ depending on how your clientele population is. And over here, we do see a lot of footballers, volleyballers, and handballers. The duration of symptoms is more than a year and a half. Okay, so these are all chronic. And shockwave works very well with chronic patients. Unless you're talking about fractures, which will be usually slightly more than 2 months. Or stress fractures where you can actually start treating earlier, like 1 month. So the location of a treated area, the most common areas are the foot, followed by the knee, ankle, and shoulder. Less common, elbow, leg, hip, and thigh. And tissue type, which is most common, is tendon, followed by fascia, joint, and bone. And we hardly treat ligament and skin. And over the next few slides, we'll look at the pain response and also how they actually deal with the tissue healing. Obviously, we did not look at treating or evaluating tissue healing. We did not manage to actually do imaging studies, which we did for some of the patients, but it was very interesting. And the rest of the pictures just show the activities that we did with the rehab department. And over this, I went for a few courses looking at using ultrasound to actually treat my patients. This is one of the presentations that I did in Prague on the focal cartilage defect. And obviously we have a whole lot of happy people who actually were shocked by themselves and their colleagues. This is a picture of Professor Heinz Laurer. And I showed this picture because he's one of the pioneers in the field, and also he is one of the Olympic doctors who actually takes along shockwave device to the Olympics for the German team. So this is my family. When I'm not doing shockwave, I hopefully spend a little bit of time with my family, and they've been telling me you are doing too much work and you need to go home, and that's part of the reason why I'm going home. Okay, so when you look at a mean pain change according to region, we find that shockwave works for almost every part of the body. And you see the two which are in red. These are outliers. They don't work because for patients who are coming with chronic fractures, they have no pain. And for fingers, sometimes there is very little response when you treat chronic scar tissue. But it all works for most of the region from anything from minus 2.3 to minus 2.9. And if you look at different tissue types over here, you can find that it actually works for all different tissue types, and much better in fascia, joint, tendon, and muscle, and bone. But you can see that if you treat bone, you will need to use other measures to evaluate healing, which means your X-ray and CT scan is very important. Pain is not a very good indicator of healing for fractures. When you look at tendon types, we look at whether the patients who had tendon injuries were doing better or worse than non-tendon injuries. We found that they responded almost the same. And if you look here, the one in green, where is here, for calcific tendinopathy or ossification in the tendon or antisophytes, they do respond very well. Now, this is a very busy slide. If you look at the top 32, where you have at least 20 treatments, we have all these conditions. And the top 8 are above 100, and the following 10 or so between 50 to 100, and the rest are below 50. So we will go through this slowly. Over the next few slides, we'll go through the common indications, followed by less common indications and the difficult conditions that we treat. So over here, these are the 15 indications which are most common. As all of you will be able to tell me which is the most common indication, plantar fasciitis, right? Right, so plantar fasciopathy, we treated 540 of them, and followed by Achilles tendinopathy. And when we talk about Achilles tendinopathy, we need to differentiate whether it's insertional, whether it's antisopathy with calcification, or whether it's mid-substance, or whether it's partial tear. Because when you treat these things, they will have different responses, and they will have to be treated differently. So after you finish with insertional calcific tendinopathy, it's rotator cuff calcific tendinopathy. It's a very good one to treat. Can be painful. And then lateral epicondylopathy, or the tennis elbows, they are not so easy to treat, but fairly painful, and you need to be careful about this. Trochanteric pain syndrome or trochanteric bursitis. Honestly, when the radiologist does the imaging, they show the bursas. If the bursa is not big, I disregard the bursa. I'll just treat the myofascial aspect. Because once the myofascial aspect gets released, once the muscle gets rehabilitated, the patient is fine. So you actually offload that part, reduce the inflammation, and the patient is better. And followed by proximal tendinopathy in the patella, and the tibial bone stress injury. That's the right term for that. But when we first started, we didn't have that term, so we only had medial tibial stress syndrome. And Achilles mid-substance tendinopathy, as you can see over here, it's not so common, but it actually works, but it doesn't work so well. And you have the metatarsal fracture. All fractures respond very well to shockwave. And then quadriceps tendinopathy, rotator cuff tendinopathy, patella insertional tendinopathy, or an old Osgood Schlatter's, tibial fractures, and quadriceps calcific tendinopathy. So these are the 15 ones which I consider as common indications that you can shock without having to know a lot. So 10 tendinopathies, 2 fascia or myofascial pain, 3 bone, whether it's fracture or stress injury. Just as I mentioned, if you are treating the insertion or the calcific tendinopathy, they do much better than if you actually treat the mid-substance tendinopathy over here. Similarly, if you look at the rotator cuff tendon, those who are treated for calcific tendinopathy do better than those who just have rotator cuff tendinopathy. So I would prefer a calcific tendinopathy patient anytime. So for the less common newer indications, there are a whole lot over here. The next 17 are less common indications. And over here you can see that there are 8 involving joints where it involves impingement, osteoarthritis, or degenerative changes. And the next 4 involves fascia and myofascial, injuries. And the third one involves tendon where they involve partial tears. Okay, they are less common, also because they are more difficult to treat. And the final one are bone stress injuries. So I don't like to treat all bone stress injuries just because you send them to me, just because you have a bone stress injury project. So we go and through them one by one by color coding. So if you can look at this plantar fasciitis with partial tear, surprisingly, even with partial tears, they do quite well. Why is that so? Because a lot of these patients actually have spontaneous partial tears, and they don't know that they have. So if you can take someone who has no pain or a lot of pain, you compare the one which is more symptomatic or less symptomatic. Very often you can find that the one is not symptomatic is the one with a partial tear. So sometimes it's actually difficult to tell whether they actually had it before. So that is why we find that they seem to respond very well. For plantar fibromatosis, they also respond, but with a lesser extent, and it's very painful. So this is what we notice. For ITB band syndrome, they respond very well, similarly with SI joint dysfunction. So when you look at the next one in green or blue, it was blue on my computer. So these are the knee focal cartilage defects, where you can find that most often we find patients with patellofemoral focal cartilage defects. And you can see this is 108 compared to 21 over here. So this will be 5 times the amount. And find that for knee focal cartilage defects in a patellofemoral articulation, they tend to respond better than those who have in the tibiofemoral articulation. And this is just our observation. And we have not actually managed to look at pre and post MRI changes. It would be great if someone actually do that in future. So over here, you can look at AC joint OA. We find that it actually responds really well. So if they have a degenerative AC joint, we can provide shockwave, 1 or 2 sessions, they respond very well. And if you look at the knee OA, tibiofemoral articulation is minus 2.6, they also respond very well. However, saying that it is quite painful if you actually shock them to the maximum energy flux density. So I don't prefer to treat them. I prefer that you do the physiotherapy, you do the PRP, hyaluronic acid, then only send to me. Then they'll be happy to receive some pain. So if you look at the tendons, lateral epicondylopathie with partial tear. Not much pain change, but it is acceptable. If you look at Achilles tendon with partial tear, the response is quite good. And then patellar tendon with partial tear, the response is not so good. And the reason why it is actually not so good is because a lot of these patients are athletes who are continuing with training and who are still playing. And these patients come to you because they want to reduce the amount of NSAIDs they are taking. They want to play at a higher level. They don't want to look like a slouch when they are playing and to be called off the court by the coach. So they want to be able to play at a higher level. And if you look at the bony indication, the metatarsalgia or stress reaction, they respond really well. You look at the tibial anterior stress fracture, they don't respond so well. It's because many of them are already cold cases. They've had this fracture for a long time and they don't have any pain change before or after treatment. So the way to do this is to actually do a follow-up X-ray or CT scan. Difficult indications to treat. So Aziz and I looked through this and said it's impossible to look at those patients who do not respond to shockwave because everybody who comes to the clinic seems to respond. And then we came with this idea. Anyone who is shocked, who still has pain score which is 3 and above, we say that these are patients who have difficulty to treat. So fair enough, our criteria is slightly stricter than some of the studies that you see in literature looking at chronic pain where they put 4 as their criteria. So we put 3, we would drop it down a little bit more. Lateral epicondylopathy with partial tear is something which is not easy to treat because patients have often suffer a lot of pain. Adhesive capsulitis, I don't like to treat this, but the patients do get better, so they continue to come. Medial epicondylopathy, we don't like to treat this because of the ulnar nerve, and sometimes it is tricky because they still have some pain. Rotator cuff tendinopathy with partial tear, I'm not sure whether it works, but then it's difficult to treat. Triceps calcific tendinopathy is a challenge to treat because most of the time the patients come with an antisophyte, which is like 1.5 to 2 centimeter large, and they have a flare up, so they are in a lot of pain. So you will have to take another 1 or 2 sessions to actually reduce the inflammation before you shock them. So the next one, the coccydynia, is always difficult to treat patients with tailbone pain. Midfoot OA, it is possible, but it is challenging. You find that many of them still have some pain. Quadriceps myotendinous junction strain. It's a nightmare. I've had a few of these where they have high-grade strains. And like, what are you doing in my clinic? And I put here as patients who are difficult to treat over here. So possibly I will not treat these patients, I will send them to the surgeons. So we need to employ stage process depending on the extent of pain, inflammation or referred pain, along with rehabilitation and other methods of treatment. So what are the potential
Dr. Aston, 2 minutes.
Okay.
Yeah,
so, all right. So take a picture of this, go back home and read it. So I would say that we have subacromial impingement, peroneal tendinopathy, OA knee is very important because we find that they respond very well. The only thing is the pain. But if you can actually locate the area that you want to treat, if you want to get rid of the osteophytes, it's a very useful thing. The rest with fractures is standard. Okay, so we know that from this data, all your patients need less than 2 treatment sessions if you know how to treat the patients. So they don't need too many. But this is just a mean. Some of them go right up to 6 treatments. So as I can tell you, up to today, 90% of our patients do better or much better. That's a very high value. That's almost as good as what some surgeons have when they do surgery. But then this is only in my hands. So be aware that maybe 1.3% of them get worse and 7-8% of them do not feel better. And this again are the adverse events. You find that 1.5% of them get adverse events, and the most common is more pain, erythema, dizziness, unable to tolerate, and swelling and bruising. And these are the areas that you most commonly find this. And these are the indications that you need to be careful, where you have partial tears, where you have areas where you shock very hard, and the elbow. So there are various ways how you can actually reduce. You can reduce the energy level. You can use fewer pulses. You can use fewer number of sessions. And be aware of people who have fainting spells or dizziness whenever they take blood or do some procedures. Be cautious of small tendons, partial tears, or acute onset. So we do not have time to go through this, but basically this would show you all the goodies where I actually use this is the mean energy levels that I actually use. This is the evidence of what we use in the treatment of all these conditions, whether we use a unfocused probe and a soft focus probe and a focus probe. So if you have the recipe, you'll be able to treat the patients. So we have actually gone through all this. And always go back to your basics, go back to your anatomy, because if you don't know what you're treating, you're in trouble. So with all this, further work needs to be done to evaluate efficacy of shockwave, especially if you're treating post-operative indications, which is the new thing that we are doing. And also, I've suggested to Dr. Lewis, whenever we screen patients. We can actually identify those patients who actually have myofascial pain syndromes. We can actually identify those people with focal cartilage defects or osteophytes, and we have to consider whether this will actually pose a problem in season. So this is something that I've started to do. So shockwave is a very safe method. It is useful in tendinopathy, fasciopathy, impingement syndromes, and fractures. However, consistent work and more research needs to be done to demonstrate long-term validity. For continuity, more data collection is needed to explore potential new indications. Thank you.